You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is September 29th, 2023. Our topic is the evaluation of recurrent infections. Our presenter is Dr. Nikita Raje. She is an assistant professor of pediatrics and allergist immunologist at Children's Mercy Hospital, and she is also the medical director and chief in the section of allergy immunology. I'll do a brief introduction and then I'll have you take over if that's okay. So today you're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. It is September 29th, 2023, and we will be going over evaluation of recurrent infections with Dr. Nikita Raje. She is an allergist immunologist here at Children's Mercy in Kansas City. She is also the medical director and of the Allergy Immunology Clinic and chief of the section of allergy immunology. Thanks for chatting with us today.
Thank you, Dr. Lee. Appreciate the introduction. And this is for you guys. This talk is for you guys. So if you have any questions, feel free to stop me. This is going to be interactive. So please unmute yourself or put your answers in the chat. We'll have a few questions here and there. So let's get started. So disclosures, here are some disclosures, nothing relevant to the talk today. And I'm going to move ahead and talk about the learning objectives to recognize the various causes of recurrent infections, to classify primary immunodeficiencies or inborn errors of immunity, and to outline the tests for various types of IEIs. So truly, here's an outline, and we're going to start with the first question. Why is it important to work up patients with recurrent infections? So, you know, the simple answer is adjusting my screen here, to reduce morbidity, to reduce mortality of the patients with from the infections or the underlying cause. Also, prevention is better than cure. So if you prevent infections because we know what's the underlying cause, we can save some resources that are utilized for some of the hospital stays and complications that these patients face. And then the underlying cause itself can have some implications apart from the recurrent infections. So we really want to know that. So what kind of infections should we be worried about? So clearly, yes, recurrent infections is something that we should be worried about if they are more than frequent, and for each type of infection, the recurrence may have a different meaning. So maybe 3 to 4 ear infections in a year, or more than 2 serious infections in 1 year could mean recurrent. Severe life-threatening infections are also a sign where we should get worried about these infections. If an infection is in an unusual site or organ system, such as even a single abscess in the brain or liver, these are all sterile organs. And if there is an infection, we should be thinking of what could be an issue that led to such a serious infection in an unusual site. Simple infections such as sinus infections should be treatable with oral antibiotics. So if they need more than the usual treatment, so if they're resistant to optimal treatment, such as IV antibiotics for a simple infection, may need to be looked into. And any opportunistic infections, the infections that should typically not occur in an immunocompetent host, if you see such organisms causing infections, it should definitely be a red flag for us to think about some underlying cause. So now that we know it's a problem, what kind of diseases should we be thinking about? So this, yes, this is a talk on inborn errors of immunity. So yes, we are going to think about it. But a couple of more common causes are secondary immunodeficiencies and some other causes. So the other causes, so say a normal childhood infections, they can be recurrent for some kids compared to others, the extremes of age are certainly something to think about. So there are some causes that are not out of the ordinary and don't mean an underlying issue, but just that, some kids or people can get infections more often than others. And so keeping those causes in mind. So we are going to go in reverse order from, thinking about the most common causes and just kind of thinking through the other causes that can give rise to infections. So that those can be from different microbes, all kinds of bacterial, viral, fungal, opportunistic, or parasitic infections. Sometimes kids get more infections because they are exposed to secondhand smoke, or they are going to daycare. So younger children going to daycare, or they have siblings who bring in exposure to the viruses that they are exposed to, even if the child is not going outside of home. And then some of the weather changes and seasons, or viral seasons, that bring in more tendency to have more infections. And then there are some host factors, so extremes of age, some genetic factors, anatomical issues. So say there is primary ciliary dyskinesia, or just kind of smaller smaller ear canals, some kind of anatomical issues that lead them to not be able to clear the secretions. So some of the comorbidities might be similar ones. So patients having acid reflux, or patients having hypotonia, they may not be able to, they may be at a risk for having aspiration and cause more frequent infections. So frequent lung infections from aspiration, or unable to clear their secretions, and they can have frequent sinusitis. So some of these issues can, even though have no relation to an immune issue, can present with recurrent infections. So that's just a list that we talked about. Of course, there are some of the other causes include atopy. So atopic diseases, so having allergic rhinitis and other anatomical issues such as sinus polyps or nasal polyps can lead to a tendency of having more secretions, unable to clear those secretions, and then can have secondary infections. So having recurrent sinusitis can be related to that underlying comorbidity. Having asthma or bronchiectasis, so those anatomical issues, or comorbidity of asthma, can lead to tendency for having frequent infections, or infections that mimic pneumonia, right? So an asthma kid having URI, fevers, trouble breathing from the asthma can present like pneumonia. Atopic dermatitis, these patients are at risk for having frequent skin infections, and patients presenting with skin infections can mimic someone with an immunodeficiency that presents with frequent skin infections. And then we talked about anatomical issues such as primary ciliary dyskinesia, cystic fibrosis. These patients present with recurrent infections. Now, cystic fibrosis has been kind of classified into immunodeficiency classification as well. So keep that in mind. Talking about a little less frequent cause of recurrent infections, so secondary immunodeficiencies, but these are definitely more common than the IEIs. So keeping them in mind, that there are some factors that can suppress the immune system, such as there are infections that can actually cause more suppression of the immune system and then lead to more infections. So HIV, EBV, CMV, all these viruses can suppress the immune system. Nutritional issues like zinc deficiency or protein calorie malnutrition can definitely be a factor as well. Some of the medications such as corticosteroids or chemotherapeutic agents. There are some biological agents or irradiation that's used for some of the cancer therapy can lead to suppression of the immune system and cause infections. Some of the simple medications such as anti-epileptics, they can lead to lower protein levels and lower immunoglobulin levels. So keep that in mind when you are evaluating a patient with low immunoglobulin levels. Some of the immunosuppressants, such as azathioprine, can reduce the number of lymphocytes. So you might see those patients with lymphopenia. You have to look at the medication lists just to see if this is secondary to any of the medications. Asplenia can be from trauma. It can be congenital. There is a genetic cause that's classified as an inborn error of immunity as well. So keep that in mind as well. But asplenia can come from different reasons. We talked about the extremes of the age being an issue, protein losing conditions. So enteropathy, nephropathy, where they lose proteins, they also lose immunoglobulins and can lead to hypogam. And then diseases such as cancers or autoimmune issues can also suppress the immune system in different ways. And then we come to the rare cause of recurrent infections, which are inborn errors of immunity. So these are the zebras, but these are the ones that we want to be focused on today and just kind of go into the details of how we would work up patients with recurrent infections when we suspect inborn error of immunity. So just a recap, you all know cells of the immune system come from the stem cell, and they can be lymphoid or myeloid cells. And then these cells and some other factors in the body, such as physical barriers, skin, epithelial layers, proteins like complement tool-like receptors, all of them come together to provide the immunity, and immunity can be innate immunity and adaptive immunity. Right, so want to keep that in mind when we evaluate these patients. Are we talking about recurrent infections that are more due to defect in the adaptive immune system or innate immune system? And then the immune response from all these factors is really important when we evaluate our patients, because there are patients who, there are kids who will be running around and, getting exposed to everything around them. So for example, here there is a patient who has a splinter in the toe, just running in the yard, and that splinter might have bacteria virus on them. And when that bacteria breaks that physical barrier of skin and gets into the body, it has already broken the first line of defense, which is the skin. And so when that happens, there are other layers of immune system that are ready to fight, such as the sentinel cells, macrophages, dendritic cells, mast cells that are in the tissue ready to fight that infection that might have broken that skin barrier. And those cells start releasing cytokines or proteins that go to the blood circulation and send a message that there is a problem. So then they ask for help, and the neutrophils are the first responders who come to the site to help these cells in their fight against the microbes. Also, the dendritic cells take that message through the lymphatic vessels to the lymph nodes, draining lymph nodes in that area. And there, the T and B cells are going to make a plan on how to fight that particular infection. And so the T cells make cytotoxic T cells that might come to the site, helper T cells that will help the overall fighting in the infections. And then the B cells make antibodies. And so they go to the bone marrow. The plasma cells will make IgM first and then switch to G, A, or E. Depending on the type of infection. So that's the basic of how the immune system works. And so let's see, why are we worried about these inborn errors of immunity, right? So over several years now, we know that the number of genetic causes that we are aware of has gone up tremendously. And so if you look at this chart here, say 1980s, where we came across immunodeficiencies, initial immunodeficiencies were discovered. Over time, we increased the number of the knowledge about the number of genes that cause immunodeficiency. But that has expanded a lot since the genetic technology has improved. And at this point, we know more than 485 genes, so close to 500, and likely we have crossed that number already of the genes that cause immunodeficiencies. So this is the classification given by International Union of Immunological Societies that classifies IEIs into 10 categories. Combined immunodeficiencies, combined immunodeficiency syndromes, where T and B cells are both involved and other systems may be involved, predominant antibody deficiencies, there's diseases of immune dysregulation. So other than that, the immune system's not working enough, so it cannot fight infections. The job that the immune system does actually causes damage to our system, and that immune dysregulation causes a problem as well. Congenital phagocytic disorders, defects in intrinsic and innate immunity, autoinflammatory disorders. So these are disorders where there are either periodic fevers or inflammation that looks like infection, but there is none, and there are signs of inflammation that continue to be there, whether it's inflammation in the bowel or in the joints and things like that. So lots of different disorders, complement deficiencies, bone marrow failure disorders, and then phenocopies of IEIs. So these are the 10 categories. And this is the latest update on their classification. And that tells you how every couple of years, there are several inborn error of immunity genes added to the classification. So there were 55 new IEI genes from 2019 to 2022 when this update came out. So how common are the IEIs? So there was a initial population survey done in 2007, where researchers just called general population and asked if they have an immune issue. And 1 in 1,200 replied they had an immune issue. Now, that doesn't mean that was an inborn error of immunity, but that was the first initial guess or initial data that was shared. But now we know that the inborn errors of immunity are can vary. The prevalence can vary depending on the type of immunodeficiency. Selective IgA deficiency, for example, is pretty common, 1 in 300 to 400. With the newborn screening for SCID, we know that the prevalence of SCID has been more defined. It was thought to be around 1 in 58,000, in some populations 1 in 100,000. For chronic granulomatous disease, 1 in 250,000. Overall, the prevalence is thought to be about 1 in 10,000. Some of the newer defects are extremely rare, and the exact incidence is not yet determined because they might not have been screened for as much. So moving on, how do we evaluate recurrent infections? And as this slide suggests, the most important part of that whole evaluation is history. But then in practice, everyone comes with recurrent infections, right? So how do you know who to evaluate for inborn errors of immunity? So this was a chart that was that's advertised by Jeffrey Modell Foundation. This is a foundation for immunodeficiency patients, and that increases awareness about IEIs or immunodeficiencies. And they came up with this 10 warning signs that help physicians or providers outside of immunology to determine when should they be suspecting IEIs. So as per this chart, patients who are having frequent infections, recurrent infections, failure to thrive, family history of immunodeficiency, opportunistic infections such as thrush, deep-seated infections, or need infections resistant to optimal therapy and need for IV antibiotics, all of these can be signs of immunodeficiency. Out of these, the family history of immunodeficiency has been termed to be a really important piece. So if you come across that in a patient, definitely think of a workup for IEIs. Does the type of infection matter? So some of the infections or microbes can help us narrow down what kind of IEI to think about, such as Serratia, Mersens, Burkholderia cepacia, Staph aureus. All these infections by catalase positive organisms can be part of a picture of chronic granulomatous disease. HSV encephalitis can be a patient who has a defect in TLR3 pathway. Enteroviral encephalitis has been noted to be a problem with XLA patients. Now, EBV can secondarily suppress the immune system, but also there are some IEIs that are known to be prone to having chronic EBV, and that can lead to lymphoproliferation. So there's a long list. I've listed some. Same for HPV, chronic mucocutaneous candidiasis. SCARD9 is known to cause invasive fungal infections. And then with SARS-CoV-2 infection, we know that about 2 to 3% of severe life-threatening infections have resulted from various IEIs that have defects in defense against the viral infections that are noted here. Apart from the history about what type of infection, it's really important to know the comorbidities. Some of the other features of immunodeficiencies include granulomas, autoimmunity, atopy, lymphoproliferative features, as well as malignancy. So if you see a combination of these going on along with infections, definitely think of IEI workup. So some of the clues, such as if there are autoimmune features, so if you see autoimmune neutropenia or hemolytic anemia or thrombocytopenia, there are some immunodeficiencies that should come to your mind, such as CBID, autoimmune lymphoproliferative syndrome, 22q deletion syndrome. These patients can present with autoimmune features. Cytopenias are the most common feature of autoimmunity in IEIs. Apart from that, GIA, thyroid issues can also occur. Immune dysregulation. So if you see lymphoproliferation, think about EBV-associated IEIs. Malignancies can occur in several different types of immunodeficiencies, antibody deficiencies, combined immunodeficiencies, immune dysregulatory disorders can all present with malignancies. Atopy, so allergies, eczema, asthma can occur with certain types of IEIs, such as hyper IgE syndrome with STAT3, DOC8, Wiskott-Ulrich. All of these patients can present with atopy. How about the physical exam? So some of the features can be helpful in your evaluation. At times, the exam may be completely normal, and that doesn't rule out or shouldn't sway you from doing a workup for IEI. So patients may have dysmorphic features that can, typical features of a particular syndrome that might be helpful, such as coarse features can be seen with hyper IgE syndrome caused by STAT3. Typical features with midline defects can be and the typical faces with 22q deletion may be present. Failure to thrive may be a feature of T cell deficiencies. Short stature might be found in some patients, such as cartilage hair hypoplasia or STAT5B defect. And so some of these features can help you look at specific causes of IEIs. Absence of tonsils or lymph nodes can be a sign, particularly in XLA or SCID. Hepatosplenomegaly, lymphadenopathy should prompt you to look at lymphoproliferative disorders. Rashes can be helpful sometimes, and then signs of any kind of syndromes that we just talked about. Ectodermal dysplasia, so conical teeth, sparse hair, nail defects, skin defects can be part of the features of patients who present with ectodermal dysplasia and immunodeficiency. And then, of course, lab evaluation is important. For some of these patients, we start with the screening tests. Depending on what kind of immune defect you are thinking of, the screening test might differ. So for antibody deficiency, you would get immunoglobulin levels, specific antibody titers, so vaccine titers, and then response to booster vaccines. Those are the basic tests. You can get flow cytometry to look at B cells and B cell subsets, naive and memory B cells, transitional B cells. There is advanced functional flow cytometry that can look for particular proteins such as BTK for XLA, suspected XLA patients. And then molecular testing or genetic testing is part of that evaluation. For cellular testing, you would get a basic cell count that would give you absolute lymphocyte count, flow cytometry looking at lymphocyte subsets and naive and memory subsets of T cells, and then delayed type hypersensitivity testing, no longer as much done, and we use the proliferative response to mitogen antigen stimulation more so often for functional testing of T cells. And then newborn screening for severe combined immunodeficiency is now being conducted in all 50 states of the United States. So that's definitely helpful to look for these patients, screen for these patients. And then looking at some of the advanced testing for T cells, molecular testing is definitely helpful. Microarray, looking for copy number variants, CNVs, can help look for 22q11.2 deletion or duplication and some other causes that can lead to low T cells. Molecular testing and sequencing tests are also important. So as we talk about these tests, flow cytometry is a very basic test, and you might have already had a talk to discuss this briefly. What is flow cytometry? It's just a counter. So what is done is, as a sample is taken and the cells are stained with particular antibodies and fluorescent dyes, and the antibodies or cell markers, CD markers, have antibodies, and those cells are tagged with those antibodies. So as they flow in one file, the laser is shown, and that scatters the light, and the fluorescence that is emitted is looked at by the machine, by the computer system, and shown in histograms to show what cells are high or low, or count those numbers. So that's flow cytometry in a nutshell. Testing for phagocytic disorders, so cell counts, again, gives your absolute neutrophil count that might be helpful. The function of these neutrophils can be looked at by various tests. For example, the dihydrorhodamine assay is used for checking for chronic granulomatous disease. There is a flow cytometric test, again, for leukocyte adhesion defect, looking at cell markers called CD15, CD18, and those are important. And then again, genetic testing is definitely helpful. Here is a histogram from dihydrorhodamine assay that is called oxidative burst test for chronic granulomatous disease. And you can see some of the, so the first histogram here shows a normal person with good fluorescence. So what happens is, once you take the specimen, the neutrophils are isolated, and then they are activated with a stimulant called PMA. And once they are stimulated, if they have an oxidative capacity, the tagged cells with dihydrorhodamine are going to be oxidized. The DHR is going to be oxidized to rhodamine, and the rhodamine is fluorescent, so there should be fluorescence if there is good oxidative burst. And so the histogram shows if there is fluorescence, which means there is good oxidative capacity, the graph will shift, and that shifting is showing the fluorescence. If a person has CGD, the fluorescence is not going to be there, so there is no shifting of the graph, and that tells you that the patient has CGD. Apart from giving the information, and then there might be some milder cases of CGD where they might have intermediate, some neutrophils with intermediate form of fluorescence and shifting. In general, with this test, you would look at the fluorescence and that shifting, but you also look at the mean fluorescence intensity. That's helpful, as well as the stimulation index. So that's a comparing ratio of the stimulation index between the patient and the control, and that helps you determine the oxidative capacity of the remaining neutrophils. All right, moving on, testing for complement defects. The screening test looks at the overall picture for the classical pathway by CH50 level, alternative pathway AH50 level, and then there is another one called MBL. However, MBL testing is really controversial. A lot of patients might be walking around, or people might be walking around with low MBL and not have any issues. So we don't typically use MBL. We order CH50 on several patients because these patients can present like antibody deficiency, and then AH50 might be for specific patients. Overall, the workup is determined by CH50 and AH50 level, and that's how the algorithm works on which one is low, or if both are low or both are normal. Based on these screening tests, you can order individual complement levels. Looking at the innate immune system, you can order toll-like receptor functional assay, and there are some stimulants that are used to look at whether the toll-like receptors are able to go through the downstream signaling that leads to cytokine release. And so that's how the testing is done. There is a cytotoxicity assay for NK cells that is less often used at this point, and then more frequently we use a test called CD107A that is a marker for the cytotoxicity. And then flow cytometry can be used for looking at the NK cell number, and again, genetic testing is helpful in some of these patients. Apart from that workup, other lab testing may be helpful in looking for secondary causes of immunodeficiency. So making sure looking at HIV, EBV, CMV, inflammatory markers like ESR and CRP, looking at the peripheral smear, biopsy of the affected tissue. These might be simple things that you can do to help you with the workup. All right, so moving on, I mentioned genetic testing with pretty much every part of that immune evaluation. And so why do we get genetic testing? And the answer is the same. We note so many genes at this point that can cause immunodeficiency. Knowing the underlying gene can be helpful in targeting that particular pathway, and knowing the implications of that particular gene defect, not only for infections, but non-infectious issues as well. So again, going back to the basics, here's a cell with the nucleus, and the nucleus has the chromosomes. So the DNA is arranged in that double helix, and that the information flows from DNA to RNA in the codon. So the codons are made out of nucleotides in triplets, and then the RNA that's transcribed to RNA, and then the RNA is translated to the protein, right? So yes, we can get genetic testing, but remember, when we are looking at the gene sequencing or other genetic testing, we are looking at DNA. So there are some parts of that of the evaluation that we are not looking at, such as RNA or protein level. So even if the genetic testing is normal, there is a chance that the defect, we did not find the defect, and there still could be a chance that this is an IEI. So your level of suspicion for the workup is really important to determine whether you want to pursue more testing despite normal genetic test results. So we want to talk about all kinds of genetic testing, and there are so many out there. So how do you determine which one to get, and what does it mean when you order one genetic test? Is that enough or not? So to understand what the genetic testing is looking for would be helpful to know what would you be missing and when to get more testing, depending on what your suspicion is. Right, so it's a library of genetic tests, and I'll explain what I mean by that. But here is a picture of the genome, and if you look at the whole genome, when we order the exome study, right, the exome is a test that looks for the genetic issues with the coding genes, right? The genes that code for protein. So that's about 1% of the whole genome. So you're really looking at a very small piece of the overall picture, and that's so intricate for the overall DNA that's present and is can have defects outside of that exome. So the different types of tests are karyotype. So say you are in a library and you are asked to see if there is a missing book, right, in the shelf. Think about an ideal library where everything is arranged how it should be, cataloged and put in order. And so you kind of move back from the aisle and are making sure that any of the book is, if there is any book missing or is a kind of not arranged in the right way. And that's the purpose of karyotype. When you order a karyotype, you are just looking at the chromosomes and seeing a faraway picture, zoomed out version of that picture, looking at whether any of the genes are, sorry, any of the pieces of chromosome are not arranged in the right way, or if there is a missing chromosome or an extra chromosome. That's the purpose of karyotype, right? Looking for example, the example of that would be trisomy 21. Then you can order a microarray. And what does microarray do? Well, if you are asked to go ahead and look for a missing page in the library, really standing out across the library and looking at the books wouldn't help you. So you have to go to the aisle, pick up a book and turn the pages to see if there is any missing page, right? And look at that information. And that's what microarray does. It goes through a gene to see if there is a missing piece of a chromosome or an extra piece of chromosome that's added to that. And that's your microarray in terms of the genes, where if there is a copy number variant, such as 22q11.2 deletion, 22q11.2 duplication, so all kinds of deletion duplications you can find with microarray. The older version of that test was FISH. We rarely use FISH. FISH was used for 22q deletion, but we know that it can still, at this point, with the number of variants that we know, copy number variants we know, we could easily miss some of that information. So just kind of keeping in mind that microarray is a test that is preferred at this point. Single gene sequencing. So when would you order that? Single gene sequencing is sequencing in general is when, say, you are asked if there is a missing word or there is a spelling issue, any of the words are misspelled in a book. And so really, again, the karyotype won't do that function because you are way far away from those letters, so you won't be able to find that information. Microarray can't do that either. So then you have to really sequence and look at that each nucleotide to see if it's like a spell check, and you are going through that particular gene and looking if it is spelled right? So you have to open the book and go word by word rather than looking for a missing page or missing word. So you're looking at each of the letters to see if there's a missing letter here. So that's your single gene sequencing. And that particular test is helpful if you have a patient where you know the most common cause, and that's the one gene that you are suspecting, right? So for example, patient with XLA, if there is a patient with antibody deficiency, right age, right presentation, right lab work that you are looking at, and you suspect XLA, you know that the gene that causes XLA is BTK, you can just order sequencing for BTK and get that answer. But sometimes that's not the case. You have severe combined immunodeficiency patient. You don't know which one of those genes that cause SCID is a problem in your patient. And at that point, ordering one gene may not be helpful, may not be efficient. And so you would typically order a gene panel where you are doing the same kind of process of spell check, but you are doing that for several genes of a panel of genes. Exome sequencing, I showed you, it's like 1% of your overall genome, but that's all your protein coding genes. So it's still helpful to go through and think about exome sequencing when there are multiple systems involved, such as a patient with very early onset IBD. Genome sequencing, when you have undiagnosed IEI, despite doing some of the workup that we just talked about, you can move ahead and get your whole genome sequenced as well. And then RNA sequencing, against advanced testing, it was typically not available clinically, but there are some places that have started using RNA sequencing clinically as well. But otherwise, all your rest of the testing was looking at DNA. So there is another level where if your DNA looks okay, is there testing that can look at the expression of these genes to see if that's a problem, or if there is post-transcription modification that can affect the function of these genes. So that's your typical workup. Sometimes there can be situations where the genetic testing can give you some clues, and you may need the second layer of RNA sequencing to clear up some of the questions that might come up. So what kind of IEIs are we thinking about when we see these patients? And really, it's looking for a needle in a haystack, right? So all these immunodeficiencies that we think about. So let's go through some cases here quickly. If you want to, give me a few answers here, feel free to jump in. A 6-year-old boy was noted to have recurrent sinus infections, needed IV antibiotics, episodes of pneumonia, ear infections. He had gastroenteritis. He has no other chronic medical conditions. What do you want to know in the history?
Does he have like any other comorbid conditions or like any like pertinent birth history or anything?
Normal delivery, full term, no complications at birth or after birth.
Is he growing appropriately, like in weight?
Yes, normal growth.
And
normal height and weight.
Any family history of immunodeficiencies?
Family history. One of the maternal uncles had a similar issue and is on immunoglobulin. What types of labs would you get?
CBC.
Good answer. Always the right answer.
Oh, also, are they vaccinated, by the way? Sorry, before we get to labs.
Correct, yes.
Okay.
Patients vaccinated. It's a good question.
I mean, just the basic immune workup to kind of start with, I feel like we do this with all of our patients.
Immunoglobulins.
Yeah, you kind of go
a flow.
And a flow and
antibody titers.
Awesome. All right.
You do the things, yeah.
Right. And name any immunodeficiency that fits this picture.
I mean, I'm even thinking about like a lot of B, like even like the B one, so even like a like what's like a Bruton's or something like that, like a yeah, dude, all the ones with these, yeah, like
any antibody deficiency. Yeah. All right. So again, moving on to just discussing B cell deficiencies. Remember the boy with the splinter in the toe, their innate immune system and the sentinel cells would do their job. The information would get to the lymph nodes, the T cells start doing their job. The B cells, if they are defective, this is the part that's defective, but some of the innate immune response would still be normal here. And so if these patients can either do not have B cells, or they do not have enough antibodies, or do not have functional antibodies, they present with cyanopulmonary infections and GI infections as well. And so some of the features of these antibody deficiencies, the things that I've written in blue are differ by the different antibody deficiencies. So pay attention to that. If it's AGAM patient, there are no B cells, no immunoglobulins, and because of that, no response to vaccines. And the most common is the X-linked, which is caused by a gene called BTK. But some of these patients can present with autosomal recessive gene defect. And so keep that in mind. So mu heavy chain or lambda phi, Ig alpha, Ig beta, blink, PI3K defects, and so the list goes on. Some of the transporter genes here. So all of them can present with AGAM. These patients have typically present after 3 to 6 months of age when the maternal immunoglobulins disappear from the circulation. Bacterial infections are the hallmark, but can have viral infections as well, and replacement of immunoglobulins is the treatment. Compared to common variable immunodeficiency, where B cells are normal, no immunoglobulins or low immunoglobulins, and response to vaccines is low. So again, a long list of genes. They present a little later, typically after 2 years or 4 years of age, and bacterial, protozoal, viral infections can occur, and they can have non-infectious issues as well. So they may need immunoglobulin replacement or other immune medications for the non-infectious issues. Selective IgA deficiency, B cells are normal, immunoglobulin G, M, E are normal, A is low or absent, and they have IgA less than 7. There can be variable response to vaccines depending on whether they are symptomatic or not. They may have infection, they may need treatment or just monitoring. Treatment may involve prophylactic antibiotics or, in rare cases, immunoglobulin replacement. And these patients can have autoimmunity or can evolve into CVID. Specific antibody deficiency, B cells are normal, immunoglobulins are normal, response to vaccines is low. And these patients, again, depending on whether they're symptomatic or not, they may need boosters for vaccine, prophylactic antibiotics, or immunoglobulins. And transient hypogam of infancy. Here, the immunoglobulins are low, but the B cells are normal and the response to vaccines is normal. Most of these patients will present after maternal immunoglobulins disappear, but the transiently low immunoglobulins improve after 2 to 5 years age. They are mostly asymptomatic. If they have infections, they may need some treatment. Case number 2, 5-month-old is sent in for immune evaluation for frequent infections and poor growth, frequent thrush, chronic runny nose and congestion. What do you want to know?
Yeah, scared.
Well, you might want some more history. Because I don't have anything on the slide, so I can easily change the case, right? When you ask me questions, so feel free to ask me questions.
That's not nice.
No, I have everything written down in front of me, so I'll tell you exactly what I want.
I always like to ask about like birth history, maternal history, like does she have
Yeah.
HIV, anything like that?
So no HIV. When the baby was born, had some breathing issues, and they had to do an echocardiogram and found a hole in the heart. Yeah. What else?
Weight gain?
Have they had a, what'd you say, Sosa?
Like weight gain? Like, I mean, like, is the kid gaining weight?
Is gaining weight, but poor growth. So slowly gaining weight, but not, the height is less than 5th percentile, weight is at 5th percentile.
Did we have a normal newborn screen?
So the newborn screen was low risk abnormal.
Any like abnormal exam findings, like abnormal faces or anything like that?
Yeah, so midline defects, typical faces with has some dry skin, hypertelorism, and low set ears.
Do they have a thymus?
Good question. So what labs would you like to get? So you're on the right track, right? So what labs would you like to get?
So like flow
CBC.
cytometry.
Good. All right. So has low T cells, has low platelet count. So name an IEI that fits the description.
You said low platelets as well?
Correct. And there's no single answer, it doesn't have to be one answer, but just some things that come to your mind. something that fits low T cells, low platelets, like abnormal newborn screen, all of those can still be in the differential, right? So kind of keep that in mind, that broad categories. What comes to your mind?
I was still thinking of SCID. I was thinking like a 22q.
Okay.
You said
Spring 21.
All right, those are all right answers. So good job, guys. So T cells, yeah, so defect in T cells, the innate immune system is still good. Because the T cell is defective, the B cell function can also be low. So these patients, you have to ask, are there enough T cells? If there is no help from T cells, or the cytotoxic T cells don't do their job, or they don't help with the regulation, it can cause lots of different T cell defects. Severe combined immunodeficiency patients present pretty early in life with lots of types of infections, opportunistic infections, but they'll have the failure to thrive, recurrent diarrhea, rashes, and then treatment, of course, involves stem cell transplant or gene therapy, and then enzyme replacement for some causes. I'm not going to go through the subtypes, but depending on the immune phenotype, they can be T minus, B minus, and K minus. They may have B cells, they may have just NK cells, they may have only T cells that are defective, such as 22q deletion or some other gene defects. So all these gene defects that I mentioned for each of these phenotype come in handy to narrow down the cause. Newborn screen, what is it? So if the T cells rearrange their DNA, in part of that, they cut out a portion of it and paste the rest of the DNA in green, that's pasted to each other. And then the rest, the cut out portion or the excised portion, it forms a circle. And if that's if that's low, then you get on the PCR test that's done, the T cell receptor excision circles, or TREX, if they are low, you have to get a confirmatory test to see what's going on. This just shows the same thing, the TREX that's formed when the VDJ recombination is occurring in T cell DNA. There's a lot of information about abnormal newborn screen. The typical things that we are looking for is typical SCID, less than 300 T cell CD3 cells, leaky SCID where they are higher in number, but the naive T cells are low, and then same for Omen syndrome with a typical picture with high eosinophils and high IgE and lymphadenopathy, erythroderma. There can be syndromic causes of abnormal newborn screen or secondary causes such as cardiac defects or congenital anomalies. And then preterm infants can also have low T cells. And then sometimes it's just idiopathic low T cells. There are lots of combined immunodeficiencies that can cause low T cells. So kind of keeping that list in mind. I can't go through all of them. Coming on to some of these syndromes, one of them is hyper IgM, where the innate immune system is fine. The T and B cells can start doing their job, but there needs to be communication between T and B cells. If that's defective, such as a defect in CD40 or CD40 ligand or AID or UNG, all of these defects cause high IgM, but the rest of the immunoglobulins will be low, the vaccine titers are low, they can have infections with bacteria, opportunistic infections, and may need therapy with stem cell transplant. There are lots of other syndromes with combined immunodeficiency. Some of them that are noted here, we already talked about. So again, not going in details, but just making sure that you understand. Wiskott-Aldrich syndrome, it's a triad with defect in WASP gene with thrombocytopenia or small platelets, eczema, recurrent infections, and treatment involves stem cell transplant. 22q deletion, we talked enough. This was a patient I was trying to describe. These patients, if severe cases, less than 1% of these cases will have thymic aplasia or congenital athymia. Those patients will need thymic implant or transplant versus rather than bone marrow transplant. Hyper IgE syndrome, that's the coarse facies that I was talking about with STAT3. But again, there are lots of other genes that cause a similar picture. 2-year-old girl presents with perianal abscess that grew, Burkholderia sebaceous. What's the diagnosis? What labs would you want?
Oxidative burst test.
Okay.
Yeah.
All right, so that's the correct answer. Phagocytes cause our first responders. They run in the circulation, blood vessels all the time. When they are called upon, they slow down in the circulation, move out of the circulation, go to the site of infection, and then help in killing those microbes, right? So if they are low in number or their function's not right, there will be poor wound healing and skin infections, subcutaneous infections. Some of them cause abscesses, others cause lack of abscess with infections, and they can have other infections in granulomas. Leukocyte adhesion defect, if the brakes on them, they have to slow down in circulation. If the surface markers or adhesion molecules are absent, then they can have, they cannot move and they are trapped in circulation. Defect in different genes can cause LAD type 1, type 2, and type 3. LAD type 1 is the one you typically hear about, delayed suppression of umbilical cord, no pus formation, and high neutrophil counts, and those patients need transplant. LAD type 2 is a problem with development and growth rather than, and less of infection issues, and LAD type 3, bleeding issues along with some infections, but these are two milder forms. Chronic granulomatous disease, they do their job with phagocytosis, but once the microbe is inside, they need NADPH oxidase system, enzyme complex to make the reactive oxygen species that then turns into hydrogen peroxide and bleach, HOCl. So if this NADPH oxidase is defective, the chemicals that are needed to kill the microbes are missing, and so they get CGD. Because of they have catalase positive organism infections, and we talked about the diagnosis by dihydrorhodamine test, and treatment involves stem cell transplant or gene therapy, and then triple prophylaxis with interferon gamma, antibacterial, and antifungal prophylaxis. 5-year-old developed fever, headache, vomiting, and was diagnosed with meningitis. CSF showed H flu. What labs would you order? Name an IEI that fits the picture. What comes to your mind?
I was thinking of something that's like an encapsulated organism, and so also thinking about like a complement and things like that.
Okay, that sounds good. Yeah, go ahead.
I was saying, and if she has like a spleen or like any
Right.
like a spleen.
So that's a very good question. So there could be, either asplenia or, complement defect that because of which they have defect infections with encapsulated organisms. So see, it's not always one type of immune defect, but several different ones that can fit that picture. So good job with kind of coming up with that differential. Let's talk about complement defects. Defect in early complement. So early part of the pathway for alternative classical pathway can be different, but the final terminal complement pathway that forms membrane attack complex, if the defect is in that part, it's called late complement defect, where there are infections with encapsulated organisms. The most typical that you hear about is Neisseria infections, but then early complement pathway defects present like antibody deficiencies, sinopulmonary infections, and autoimmunity. These patients can also have lupus. 10-month-old girl who developed HSV meningoencephalitis. HSV encephalitis.
You're thinking of like a innate part, so like a like a
Yeah.
TR deficiency or something?
Yeah. So that's a good thought. There are lots of defects that can present with HSV infections, HSV encephalitis. Definitely think of TLR3, but there are NK cell defects that can present with disseminated HSV. You have to kind of think of the other causes as well, but the typical one that you would look at is the TLR3 pathway. The intrinsic pathway can cause defect with and present with infections of very specific ones, such as MSMD, will patients present with mycobacterial infections, salmonella infections, viral infections. EV is caused by warts. If you see warts, think of WIM syndrome, but there are other genes as well. Viral infections that are frequent, think of, there are lots of interferon, type 1 interferon defects that can present that way. CMCC, chronic mucocutaneous candidiasis, Th17 defects, but there are several others in that pathway that can be defective. And invasive fungal infections, CARD9 is one that we know of. Dendritic cells and PRRs, so such as toll-like receptor defects, we know these are rare. They can present with ectodermal dysplasia and then severe disseminated viral infections. We talked about TLR3, but defects in other TLR pathway can present like with severe pyogenic infections like IRAK4 and MyD88. NEMO can present with ectodermal dysplasia, mycobacterial infections, and other infections. 12-year-old boy with hearing loss, lymphedema, and atypical mycobacterial lymphadenopathy. Anything that comes to your mind? I'm going to go ahead and give you the diagnosis, GATA2, just because of time. But defect in NK cells is something to think about. These are rare. These can be low in number, such as GATA2 or MCM4, or it can be an functional defect. And in some of these patients, so CD16 defect, they can have very specific presentation. And this is the last case, 10-year-old girl presents with recurrent thrush, vaginal candidiasis, vitiligo, low calcium, presents with low blood pressure, noted to have adrenal insufficiency. Can you think of anything? APSED, so APS1, so infections of disorders of immune dysregulation. And there are lots of disorders that can present with specific infections, and we went over some of these. So that was the last slide here. I know we are just about at 11, but I just wanted to take a minute and see if you guys have any questions for me.